So before I start, I just want to call your attention to a new blessed. This is Blessed Hannah Kryzanowska. She was beatified in the spring, and she's the first lay nurse to be beatified. She was a contemporary of John Paul II, and she was living in Krakow. So she was obviously practicing nursing under the suppression by the Nazis and then the communists. And she was a parish nurse before we ever had a title like that. She was community health. She taught nursing. I think she went through a nursing school at the Florence Nightingale School of Nursing in London. She was, after she had finished, I don't say this right, it's J, but I think it's Jagiellonian University, where John Paul II also attended. So she's a very creative kind of person, very much a problem solver. She interceded for a woman who, they prayed for her intercession, and the woman had had a cerebral aneurysm rupture. And Hannah appeared to her and told her she'd be okay. So she was in a coma for about 6 weeks and made a complete recovery. And so that was the miracle, because that wasn't what medicine thought was going to happen, as you might anticipate. So just wanted to share the good news that we have a nurse. So I am well aware that we've had a lot of really good talks here and about the challenges in medicine. So some of the things are going to be overlapping, as you might expect. We have some of the same challenges in nursing as well. With the added issue for me that makes me really sad is a lot of the Planned Parenthoods are staffed by nurse practitioners and nurse midwives. It's misguided thinking about reproductive rights. And so those are the same issues that come up in nursing. So in 1951, Pius XII was speaking to Italian nurse midwives, and this was a time where we already had the rhythm method. We'd had Costi Connubii come out. He was very on top of the idea that we needed to stay the course with the church's teaching. And so what he told those nurses was that they should be informed. It wasn't the physicians or the priests that should be teaching these couples about natural family planning, although I don't think it was called that quite then. It was them. It was their office to instruct married people. And he didn't use mild language. Your apostolate demands of you as women that you know and defend this theory. And I never knew about this address until about a year ago. And I don't know how many of you have heard about it, but I was rather stunned. And that we should obviously know and defend the moral law. And then you're probably already familiar, I didn't see it come up, about what he said to hematologists just about the time the pill was in its final clinical trials, that we can't use those steroids for the purposes of contraception, and but they can be illicitly used to treat a serious organic dysfunction. So we didn't ever hear about him in this regard too much. And then, of course, we've already been over Humanae Vitae, so I'm not going to really repeat that. The physicians and nurses, when I read this the first time, I was amazed. I had, like probably many of you, I had a lot of opinions about church teaching, but hadn't bothered to read very many of them, right? That is a unique combination of arrogance and ignorance. So when I found out the truth, I was pretty amazed at this, and encouraged very early on in my reversion journey to read Humanae Vitae, and I was really impressed. So shortly thereafter, the nurse who was first involved in writing a lot of the instructional objectives was actually a Dr. Mary Martin, who was an RN and a PhD educated at Catholic University. And she used the materials, the information they had at the time, and wrote up instructional objectives. So she got us on the road to an organized approach about teaching NFP. And then John Paul II, of course, wanted us to have centers for natural methods of regulating fertility, and that he also recognized that it belonged to healthcare personnel. And so I think that John Paul II would be happy with the progress that Creighton Model has certainly made, that we have different varieties around the world, and that we are making progress in this regard. So the barriers that I have identified is this struggle with being outwardly Catholic in a workplace and lack of dignity of the human person in the rise of coworkers who have no faith. And I think if you watch the news, don't they say the most growing group of people in the U.S. are the nuns? N-O-N-E, nuns. They have no religion, and so that they identify, they're spiritual, but they're not religious. Yeah. And so we see that, and so it's that delicate balance in reaching out to the students in a nursing program and thinking creatively about how you can first identify Catholic students and their needs, and then stimulate those that aren't. That maybe they're nominally Catholic, but to stimulate their thinking. And then the other part is the attitude of colleagues. You know, I've gotten this, she's religious, you know. Somehow I'm a defect because I'm religious, you know. Or I named a talk after this one, and this was I'm currently working at Southern Illinois University, Edwardsville, and I heard this faculty member going down the hall, and she said, well, you know, Mary Lee, she's really Catholic. And I thought, you know, that's really a compliment. Thank you. And so it's that attitude. So what I have found is that part of our challenge is not just the patient care, but it is the being authentic, being on top of our game, figuring out a way to have conversations is an important part of the journey. And then the other part is the agenda of lay organizations. For example, the ANA is pro-choice. Now, I've been an OBGYN person, and I've been an ANA member, and when they came out with their position, I don't recall anybody ever asking me what I thought about that. And none of the OBGYN nurses that I knew had ever been asked. This was a decision made in the top layers for political purposes. And but that can present problems in other ways when you are trying to form students. So this recognition of life from conception to natural death, and I will tell you, this is one of the ways that I do this when I have a student who I'm trying to stimulate some critical thinking in and that has identified as Christian, preferably, and a Catholic student will identify this fairly easily. And I call on them to think about that fertilization occurs in the distal part of the tube, and it takes 7 to 10 days to implant, correct? Everybody's aware of that. So when Mary was conceived of Jesus, the Holy Spirit was there, right? And what does the Bible tell us? It said she left in haste and went to visit Elizabeth, right? Okay. So how long did that journey take to get to Elizabeth? 7 days or so, right? So the incarnation of Jesus was recognized by Elizabeth and John when he was just a little ball of cells. This pre-embryo term, right? Okay. So I have challenged people to think about that because we have such difficulty with this recognition of conception and what it means. And so it gets people to ponder that. And I have to have the right audience in order to be able to do that, but I like to make that connection for them. And then this idea of the dignity of the human person and the kind of care we give, I try to work that into how I approach these difficult topics. Because I teach nurse practitioner students, and I have to teach them the contraception material because it's on their certification exams. But they're not off the hook because they get NFP too. So they get the whole thing. And I will tell you, most students do not know what the meaning of principle of double effect is, and until you explain it to them. And so the cultural expectations then is sort of what we've already talked about, that the culture is not appreciative of what fertility awareness-based methods have to offer, because healthcare professionals aren't always appreciative of fertility awareness-based methods and what they have to offer. And so I also think that I have to be evidence-based. We have to be evidence-based in what we do. And then the competence of a clinician is important. For nurses to be patient advocates, to be fully aware of what informed consent means, and so then that's where I bring this up to NP students in particular. If you're going to prescribe this, then that woman deserves to be informed of what the method of action is. So many women don't even know how pills work, and so it's their obligation as a nurse to make sure that they do know that. And then I'm involved in research and then assessment of various aspects of practice and education. So what I bring to the table then for nurses, and what should be brought, is fertility as the normal process. And these were already discussed beautifully yesterday about restoring normal function, and this should be the philosophy that we have. It's a point of discussion that I have with NP students, and I've had with student nurses. PCOS, for example, obviously nurse practitioners aren't the ones who are going to be doing surgery if the person needs it. So my students frequently, I put cases up, I teach online, and this last summer, so I put the case up about PCOS, and the student wrote back, of course, that the woman should get birth control pills. That was the first line of treatment identified by evidence, and I don't teach it that way. And I countered back, I said, why would you give birth control pills to somebody who has issues with cardiovascular disease, has hyperlipidemia, is has a risk for gestational diabetes, when those pills raise triglycerides, change glucose metabolism, and increase her risk for cardiovascular disease and breast cancer? Why would you give her that? And so for me to ask the question back is how I do this to teach nurses to think through, to critically think. Because I think that in this area, the folks who do fertility awareness-based methods, Dr. Hilgers is an outstanding out-of-the-box thinker. He really stimulates you to think about how the hormonal stuff goes. And I've seen that in other OBGYNs that I have worked with over the years. I've seen it in, and so I've tried to do that with my students as I'm teaching them, is to make them think through what they're actually putting this patient through to choose that therapy. Could you not change lifestyle? Could you not have her lose weight? You know, those sorts of things that nurses would deal with, because nurses are doing a lot of the education. So the challenges that go with teaching for the nurse then would be making sure that you achieve competency, and what the policies would be about engaged attendance at NFP classes. With Marquette Method, we keep track of, he does a registration form, she does a registration form. About 10 years ago, I would have said 60 to 70% of the couples were sharing an address. and I don't like to say cohabitating necessarily because I really don't know if they're sexually active, but they're sharing an address. So now it's 80%, and the marriages are going down. And so you want them at the NFP classes, you want them at the intro session, but it is difficult as a teacher to engage couples who are already contracepting. And so over the years, I've kind of kept track. How many couples have I seen come to NFP who were sharing an address? The number is less than 10 couples in all those years. They might seek you out 2, 3, 4, 5 years down the road. That does happen. But for the most part, the couples that are signing up are those that are chaste. And so it's a lot of work that we have to do in the culture, but and so anyway, in St. Louis, then we have a requirement for one intro session to get married in the diocese, which I think is a good policy. I know some places that you have to do the whole NFP classes, and I would say that burns out NFP teachers because it's very difficult to teach a fertility awareness-based method and she's taking birth control pills. There are dioceses where they have to chart when they're on the pill, and that makes it quite difficult. So it varies around the country with that. And so the other concerns that you have is with couples that you're teaching is what they bring to the table in terms of delaying pregnancy after marriage, what they bring to the table as to how they see. I don't believe NFP is ever a contraceptive mentality because inherently in the practice of it, it's not contraceptive. But it can be used selfishly. And so whether or not we're dealing with that, and then going over the morality of sexual practices. So for the nurse to find education programs, we have quite a variety around the country. And we're blessed actually with that. They vary in cost. The good programs should have a length of program that's sufficient to support the knowledge of the person in NFP teaching, and then there's a requirement by the USCCB to teach 4 couples for at least 6 months and then 10 for where you've seen at least one session with them. And then probably the biggest challenge is getting a practice site depending. We have a lot of density here in St. Louis. We've placed Marquette method teachers at parishes. And in an ideal world, I think a parish nurse would be the NFP teacher. That would be a beautiful thing, wouldn't it? And so they need to have a supportive resource person, and they need diocesan departmental support, which we have plenty in our diocese here. So I've referred a little bit about teaching in NFP in schools of nursing. And so what I've done is I've initiated a study of the Catholic schools of nursing across the U.S., which I had hoped to have finished to give results to all of you. Not there. We've got IRB approval. What's turning out to be difficult is identifying deans and addresses and emails across the country to identify our Catholic schools of nursing. From what I know anecdotally, there are very few formal programs. Marquette has a formal program. When I worked at St. Louis U, I did a lot of women's health teaching. I taught a variety. I was invited to be a guest speaker in the baccalaureate programs, but it was by invitation only. And then it was interesting to me after I would go and speak to these undergraduate classes, I'd have student nurses lined up outside my door because they wanted to start charting. And I never charged a student nurse anything to work with her because they saw that it could help them. And then networking, I've been able to be invited to other universities locally to talk about my area of interest. And then so this is an informal thing, but there are Catholic schools that invite speakers from various places like Benedictine in Atchison, Kansas is a profoundly Catholic school. And they've had naprotechnology speakers come and speak to those students. They're really fertile ground, if you will. And other schools, Catholic schools of nursing, are not so blessed with that kind of support for Catholicism. I had, when I opened a center, I opened the St. Louis U Nursing Center for Fertility Education in 2002. It took me 9 months to birth that center. And the dean was Catholic. She told me I needed a powerful Jesuit to support it, and he did, and it went through in 9 months. I got dedicated space to see patients, and it was a really nice thing. But it infuriated some of the Catholic faculty that I had that opportunity. And so those are the subtle things that you deal with. And when they found out I got a center, then they wanted a center in something else. And what I did is I knew that I had to be on top of my game with that, so I had to do the research, so we were in the research projects, and do the writing and do those academic things. Like, I don't do research because I really like it. I'm just like Marguerite. But I do it because I think it's important to keep us going. So anyway, so it's an informal kind of thing. I do not have any idea right now where we're at, but we will in another year, probably. So changing the culture in schools of nursing and allied health, we have to be sure we're giving accurate information and sharing it with other schools of nursing. Now, the Jesuits have schools of nursing have a consortium where you can present the research that you're doing. And I've sent abstracts in, I've presented in a number of places. Marquette offers their Institute of Natural Family Planning. They give online courses. You can take their coursework, and they have a medical applications course as well as a teacher course. And those students are followed just as you would expect. And when we say online, it's not the idea that it's self-taught. Actually, social media is presenting some of the difficulties because patients open up a Facebook group and then they teach each other what they think is accurate about a method, but it might not be. And so we're encouraging them to, you need to discuss this with your teachers. And so I'm sure other people have encountered that with other methods as well. So one of the things that I thought of that is helpful in addressing colleagues is talking about fertility health instead of NFP. I went with the concept of fertility health. And one thing that you can get a point of discussion on is infertility rates. When people find out that globally infertility is on the rise, they hear that. And it's the elephant in the room for the millennials, how many of them, it's up to 15%. And what are the environmental factors that are contributing to that? And so, and I think I already mentioned on informed consent. So here's what I did. I had, I'm going to tell you how this came about. Now, we say that we're fertility awareness-based methods, and we say we're a couple method, right? We say that. So I had a couple in that I was teaching, Marquette, and they wanted to achieve pregnancy. So I was doing a preconception visit. I'm a big believer in health promotion. I like educating patients, and so I did the whole preconception thing with the woman, all the things that, like taking the folic acid and diet and exercise and what have you. So I got done, and the man said to me, he looked at me and he said, "So what about me?" And I thought, boxers or jockeys? And I felt ashamed because I really didn't have any really good information to give this man. And I thought, I'm taking care of a couple here. I should be able to address him with his needs. And so I looked into the literature, and I wrote 2 articles. One was fertility literacy for women in primary care, and the other was fertility literacy for men in primary care. And they have the same issues affect their fertility. So if a guy is 20 pounds overweight his risk of infertility goes up by 10%. And so I came across the information on marijuana and its effect on male fertility, which is profound. So I wrote a letter to the editor, because you notice how the press is always so gleeful every time we get another state that legalizes. But there are some benefits to marijuana, but I don't think people are being told that there are some downsides. And so, what I came across was the paradigm is that the same habits that you take on to create healthy fertility are the same habits that prevent cardiovascular disease and diabetes in both men and women. Because we're talking, when we talk about prevention of chronic disease later, it's almost like this fertility thing is a window on the future. You know? So I began to educate that way. And then last year, this makes the example. Levine did this meta-analysis of 198 studies, and done between 1973 and 2011. And during that time, and it was done in Europe, the United States, Australia, and New Zealand, so the West, right? And in that time, the average male sperm count dropped by 52.3%. That's just stunning. So that's environmental when you think about it. And so then there was another one done in Africa that came out in June of 17, and it was similar. Not as many studies, obviously, but the sperm count dropped by 57%, I believe it was. So this is a global issue. And so when I do my intro, man, do I get the attention of the guys. I get their attention about their own fertility health and how they should be taking care of themselves. So I'm trying to set up this couple mentality about that. And so these are the common topics that I go over with them. And so you can imagine the legitimacy that I get from colleagues now, nursing colleagues, because now I'm talking about fertility health. And to me, it's a better way to catch the attention so that they're more open to thinking about fertility awareness-based methods. So then with the students, I talk to them about the approach to infertility with fertility awareness, is that the person's dignity is respected. And so sometimes I tell them the story. I had a colleague that I worked with who was in part of the IVF clinic, and when they wanted to get a semen sample, she had to find an empty room. She would send the man in there with dirty magazines, and she would have to stand in front of the door to make sure nobody came in. Now talk about an indignity to that man. And that was back in like 1987, 88. So it's been a while. But so when I talk about this, I talk about the dignity of the couple and how hard it is on them for infertility workups, and the anxiety that women have. And so you all know this already about fertility-focused intercourse, and that you work closely with medical supervision. And then, you know, sometimes God wants you to be a parent, not just in the way you thought you were going to be one. It's that discussion with women to support them and couples to support them. And then I do the spiritual with them too. I ask them to pray. And I had a couple that had gone through infertility workup, refused IVF, came to see me, and she was Baptist. And so I'm talking to her and I'm saying, you really need to include prayer into this. And I said, I tell women, get your womb blessed. Mary used the word womb. You know, we use womb. Go get your womb blessed. And there are prayers for that blessing. And she goes, well, do you think a Baptist minister can do that? And I said, as far as I know, God hears the prayers of Baptists. And NFP doesn't stand for not for Protestants. So, anyway, so it is this idea that we should be offering our tools. And so, and finally, I'm a motor mouth, so I'm going a little bit fast, but I have this here because I think we are particularly sensitive with miscarriages, and that we have the Mass now of commemoration. And when you're talking with your patient about naming the baby, and sometimes burying the baby isn't an option, getting the baby blessed, and that you have this ongoing acknowledgement of that child. Now, I was in a practice with a physician who had the staff send a card on a due date, and at first I was a little uncomfortable about that. I've had a miscarriage myself, and but then I realized that for that woman, that was a really good thing that gets recognized, because that is recognizing that child. This isn't products of conception. This is, there's no sterility to this. It is how we support their dignity and handling it and make it easier for them. The other thing that I do with patients on this in a dignity sort of way, what I tell student nurses, is that the grief between men and women is different. That you need a good girlfriend, a mother, a sister, because women like to speak it out. Men, and I tell them, men are in just as much pain as you are, but that's not how they grieve. They're strong support. That doesn't mean they want to hear the rehearsal of that over and over and over again. And that's advice that people have come back to me and said really, really opened their eyes about their husband and how he was feeling, and was a good advice. And so I always talk to students about how you do that with them. And so the education of student nurses presents a lot of challenge, and when I find those openings, I take them, because there's no organized way of doing this. Now, NP students are faced with that same issue of contraception, so those, we try to get preceptors for them who will respect where they're at and allow them, but I don't think it's to the degree that physicians will find. Although my students ask if they can put in IUDs, can they, and it's very difficult for me to hear that, kind of stuff. But I follow the rules of the school, and and I make them understand how those devices work. And so it's all about that, making sure your students are on top of what is really going on, because I know that in other women's health classes they don't always get that, because I'm not sure the faculty always understand how it's going on. So anyway, so choosing your nursing practice is trusting in God. And I will tell you that I have less anxiety about NFP patients than I have about any other area of my life, because my continual prayer is, just send me who you want me to have. And I had to open a business sort of site with my Marquette, and so I had a teacher whose husband wanted us to go out and market and do all these things, and I said, no, Jesus is the business manager. We're just doing fine the way we are. Keeping up your study, paying attention to your faith life. Romans chapter 12, 1-8 has about our gifts, so I think we're continually discerning what our gifts are. And I think the most important time for me to pray is when I really don't feel confident, like coming and speaking to you all. It makes me a little nervous. Anyway, and recognizing spiritual warfare in all of this, I think is a real important aspect, because the devil really doesn't like what we're doing. So these are things that I talk to about people who ask me. And then I wanted you to know about this book if you haven't heard about this book. It came out last year, and it has chapter after chapter about different aspects of Catholic healthcare. And it has a long chapter on OBGYN. It has a chapter on natural family planning in particular. It's just a really great book, and I'm not even the way through it. I'm just barely scratched the surface on it. So I just wanted to share that with you. John M. Okay, traveling. Yeah, you can Google it pretty. Yeah. But you can look it up on Amazon to get the exact details. So, okay. So I think the panel discussion follows this. Thank you.